Hello everyone, in this video we are going to take a look at Abruptio placentae, and in addition to that we are going to learn the definition of antepartum hemorrhage. So mostly it's going to be Abruptio placentae. So first, the definition of antepartum hemorrhage. APH is defined as bleeding from or into the genital tract after the 28th week of pregnancy. After 28th week of pregnancy, but before the birth of the baby, so antepartum, so before the baby is born. This includes bleeding during the first and second stages of labor. The 28th week is considered the lower limit of fetal viability. So that is a milestone of so many things. 28th week, so that is fetal viability. The incidence of APH is about 3% among hospital deliveries, but main thing that we need to keep in mind is it is defined as bleeding bleeding from or into genital tract after 28th week of pregnancy, but before the birth of the baby. That should be it. Now, causes of Abruptio placentae. So now Abruptio placenta topic proper. First one, general factors. Next one, hypertension in pregnancy, trauma, uterine and placental anomalies, abnormalities, drug use and medical conditions. So first one, general factors. So high parity is 1 greater than 5, advanced maternal age greater than 35 years, low socioeconomic status, poor nutrition, smoking and vasospasm related conditions. So these form the general factors which are there for so many things. Now coming to specific. Hypertension in pregnancy, preeclampsia, gestational hypertension, chronic hypertension, all these are contributory factors. These can cause Abruptio placentae. Then trauma, external trauma, sudden decompression of the uterus and short umbilical cord. So external trauma can include road traffic accidents, direct abdominal impact, and sudden decompression of uterus after the rupture of membranes or membranes in polyhydramnios. So that is the second one. And then coming to uterine and placental abnormalities. Placental anomalies like circumvallate placenta, succinturate lobes, poor placental implantation, folic acid deficiency and thrombophilias, both inherited and acquired, can lead to this one, Abruptio placentae. And drugs used and medical conditions like cocaine use, hyperhomocystinuria and poor history of prior history of Abruptio placentae can also increase the risk. So before going in further details, let's take a look as to why these things cause Abruptio placentae, because we don't have specifically the pathophysiology mentioned here, because it is not mentioned in the QBank. So let's take a look. We'll create a new tab. So why do these cause Abruptio placentae? We know what Abruptio placenta is. There is the blood that is being accumulated and there is painful vaginal bleeding. So let's see here. High parity, repeated stretching of the uterus can lead to weak endometrial attachment. Yes, makes sense. Aging vasculature increases the risk of poor placental attachment. Yes, makes sense. Malnutrition also weakens the trophoblastic invasion. Alright. And smoking and vasospasm, nicotine and vasospasm causes placental ischemia. Next, coming to hypertension. Why is that? These conditions damage the maternal blood vessels, leading to vasoconstriction and increased blood pressure within spiral arteries. These can cause placental infarction, weakening the placental attachment and increasing the likelihood of Abruptio placentae. So infarction mainly because of constriction. So the vasospasm, vasoconstrictory effect leading to hypoxia is a pathophysiological mechanism for so many other conditions secondary to hypertension, that we need to keep in mind. Coming to trauma, external trauma can shear the placenta from the uterine wall, sudden decompression, same thing, and short umbilical. This is somewhat easier to imagine. Short cord can mechanically pull on the placenta. Uterine placental abnormalities. So placental attachment is weakened, poor perfusion, trophoblastic invasion is improper. So it is the same thing over and over again. And in the last one, thrombophilias, hypercoagulability leads to macrothrombi formation in placental vessels, leading to necrosis and detachment. And here there is vasospasm, here it is thrombosis leading to poor perfusion, same thing over and over again. So overall, vascular compromise, mechanical forces, structural abnormalities and integrity being compromised. So all these things can lead to abruptio placentae. It would have been nice if I could include the pathophysiology, but it is not required. If I keep doing that for every question, it will turn into a textbook altogether, after which it will lose the entire purpose of its existence. But it will be used for something else, that is a different thing. Yeah, types of abruptio placentae. There is revealed, concealed and mixed. So revealed, what happens there? Blood collects between membranes and decidua and eventually exits through cervical canal. Concealed, blood collects between the placenta and trapped within the uterine cavity, and mixed, it is some of it is lost externally and some remain concealed. So let's take a look. Abruptio placenta types. So here we can see how it is. So abruptio placenta, how in this particular case blood can go out easily, but in this particular case it is, so it doesn't have to be present here, but if the blood is being lost, that means it is revealed. If it is somewhere packed without losing, it is concealed. And then there is mixed, it is combined. Coming to clinical features, the presentation of abruptio placenta varies depending on the severity of separation and hemorrhage, whether it's revealed or concealed. So symptoms: vaginal bleeding, typically dark red. Previous one was placenta previa was bright red. Continuous and associated with pain. Previous one was not associated with pain. Abdominal pain is severe, sudden, persistent due to uterine muscle spasm. Backache due to retroplacental hematoma function. And then fetal movements, there is decreased or absent, indicating fetal distress. So that is about the fetal movement, decreased or absent. Shock out of proportion to the visible blood loss in concealed hemorrhage. So you can't tell, right, that the person is losing blood or not in case of concealed, because the blood is getting accumulated there. So in that particular case, what happens, you don't actually know. So that is, but you could see shock like features in that case. So again, vaginal bleeding, which is dark red, abdominal pain, backache, fetal movements decreased or absent, and shock. Coming to signs: uterine tenderness, firm, rigid and woody hard. Firm, rigid and woody hard. I'm thinking of woody dullness. It's a totally different thing. Yeah, we are not going there. Fetal heart rate, absent or irregular if fetal distress is present. Coagulopathy features associated with DIC and in severe cases. So coagulopathy features associated with DIC. And corollary uterus, when blood infiltrates the myometrium, leading to the uterine atony and dysfunction. So this is a separate topic altogether, which we are going to go in detail in the future videos. Coming to the diagnosis. Diagnosis is primarily clinical. We'll do this again. Uterine tenderness, fetal heart rate decrease or absent, coagulopathy, DIC like, and corollary uterus. Coming to diagnosis, yes, it is mainly clinical, but other investigations like ultrasound, coagulation profile and fetal well-being assessment is useful. So ultrasound may show retroplacental clot, but is not always reliable for detecting abruptio placentae. Retroplacental clot, but it is not reliable to detect. Coagulation profile includes PT, APTT, fibrinogen and D dimers, and fetal well-being includes CTG to detect fetal distress, because over and over again we are looking at fetal heart rate. There it was movement, sorry. Here it was, we were looking at fetal heart rate, and here it is cardiotopography that is used to detect fetal distress. Coming to differential diagnosis, placenta previa is painless. This is painless vaginal bleeding and soft uterus, but here it is firm, rigid and woody hard. Uterine rupture associated with previous uterine surgery and sudden loss of fetal station, and cervical or vaginal lesions can be confirmed by speculum examination. So these are the things, differential diagnosis. Coming to the treatment, so we have emergency resuscitation and definitive treatment. Yeah, curvature uterus is down there. Yeah, coming to the emergency, hospitalization and continuous maternal fetal monitoring is because they are losing, mother is losing blood. IV fluids and blood transfusion, yes. Large bore IV cannula for rapid fluid resuscitation because shock like symptoms could be seen. Correction of coagulopathy if DIC develops. FFP, platelets and fibrinogen are administered. Coming to definitive, there is immediate delivery, expectant management, postpartum management. So immediate, if fetal distress is present or the hemoglobin is severe, hemorrhage is not hemoglobin, hemorrhage is severe, fetal distress present or hemorrhage is severe. So vaginal delivery, cesarean section. So vaginal delivery preferred in cases with stable maternal fetal conditions. Yes, if it is stable, it is vaginal delivery. In case of cesarean, indicated if fetal distress, severe hemorrhage or maternal instability is present. So severe hemorrhage, fetal distress, maternal instability. Expectant management, if bleeding is mild, maternal and fetal monitoring with steroids for fetal lung maturity. So that is for expectant management. Tocolysis is contraindicated in suspected abruption due to risk of worsening hemorrhage. And postpartum management, because we want the uterus to contract. Yes, right? Because tocolysis is mainly relaxing. Yeah, let's do it. Let's just to make it clear. Yeah, because of uterine relaxation. Sometimes it's better to cross check. Yeah, postpartum management, monitor PPH, ensure complete placental removal to prevent retained products and infection. To prevent retained products and infection, so ensure complete removal, and NICU for support of preterm or distressed neonates. And then comes the prognosis. Maternal mortality is very 2 to 8%, which is considerable. Perinatal mortality very high, 15 to 20% due to hypoxia and prematurity, and future pregnancy risk is also high. And with this, we come to the end of this topic, antepartum hemorrhage plus abruptio placenta. In case you like this particular video, you can like it. In case you would like to say something, you can write it in the comments. And if you have any suggestions, you know where to go. I've said it repeatedly. Yeah, in case you would like to watch more of such videos, you can subscribe to this channel. Bye bye.